if Dr. Monroe's feed starts to get a little swiftly, I'll go ahead and I'll jump out of the studio here.
Hello and welcome to Northern Lights. My name is Betty Murchison, and I am chair of the Wake County Human Service Northern Regional Community Advisory Committee. And I'm here today with Ross Yeager, who is the director there. Good, you're with us, Ross. Can you?
I am.
Okay. Do you want to start, Ross, or you want me to continue? We're having some technical issues today, guys, but the show is so worth it. Please don't leave us. Stay with us so that you can see the guests that we have on today. And we will start with our presentation about Northern Lights and Wake County Human Services and why we're gathered here today. Northern Lights, the Lights is an acronym for Living in Good Health Together. And today's topic is health disparities in historically marginalized populations. And since COVID, or last year during the COVID pandemic, there was a lot of discussion about health disparities and what that means and why it matters. So we have two experts with us today to discuss that. So before we introduce our guest speakers, we will put up a graphic to show you who is responsible for this work, which is the Northern Regional Center Community Advisory Advocacy Committee. I'm sorry. And the person who's responsible for us being able to live stream this telecast is Rachel Morris, who is the executive director of the Roseville Chamber of Commerce. And we want to thank Rachel and M. Anderson, who works with Ross. They are the producers of this show, and we could not do it without their help. We'll introduce them to you a little later on. Ross, are you able to chime in now?
Yes, and Betty, everyone, I apologize so much for my technical difficulties. And just as an FYI, you will never have to worry that Wake Med will keep your information secure, because they have got like federal security here that we can't even get through. So feel comfortable that they're in 100% compliance with HIPAA. But as Betty said, we're super excited for today's show. We have two of the best docs in Wake County. I mean, there's no other way to say it. I mean, you have Dr. Peter Morris, who has really dedicated his life to serving historically marginalized populations. And then you have Dr. Rasheeda Monroe, who was right across from me here, who has really, Peter actually did her residency, was with her when she was doing her residency, and she is out there in the community making a real difference. And I'm going to let her tell her story, but it's just inspiring to see what a difference one person can make. And it's just had a huge impact on our numbers here in Wake County. So thank you. We're going to have a bit of a different format. We're going to turn the show over directly to Peter and to Dr. Monroe. I had the pleasure of working with Dr. Morris for a number of years when he was the medical director of Wake County Human Services. And I can tell you, this guy has dedicated his life to providing service to what are historically marginalized populations. And, I don't think that he needed to work after he left Wake County, but he's been now the executive director with Urban Ministries for, Peter, I don't know, I'm going to say at least 5 years. And the service they provide is beyond just medical services. It's really serving the whole person. And Peter's just the kind of guy that it's just been my pleasure to know him for as long as I have. So Peter, can I turn it over to you at this point?
Thank you.
I hope that wasn't muted.
No, I don't think so. Uh, Thanks so much. And it's a pleasure. It's a pleasure to join you here on the show, and thanks so much for inviting me to do so. Um, as Ross said, I feel really privileged to have spent all 45 or so years of my career serving historically marginalized populations. When I first trained at the University of North Carolina, our hospital was called um, North Carolina Memorial Hospital. And at that time, as I trained in pediatrics, there were very few pediatricians in the rural parts of North Carolina. So pretty much we got people sent in from all across the state. And it was an opportunity to see just how people lived in the rural parts of the state if we were willing to listen and to see um, and hear the stories of people from the rural parts of the state. And I learned a lot about the privations that people came to us with and the need to not only learn to become a really great clinician, and I think that's how we were trained to be, a clinician being someone who knows how to practice pediatrics and to make the right diagnoses and to prescribe the right medications. But when I left the university to start my first practice, I I went to one of the 10 poorest counties in the United States. It's in rural Kentucky on the border between Kentucky and Tennessee. And it still is one of the 10 poorest counties in the United States. And it's only by the grace of the families who entrusted their children to me that I really learned what it meant to be a doctor. It didn't mean only making the right diagnosis. It meant learning more about where people lived and how they got by day by day by day, because the coal mines weren't providing the same living that they used to the families, and people were living in homes up and down hills and hollers where their walls were papered with newspapers, and the cold seeped in through the shack walls, and there were big pot-bellied stoves in the middle of the houses where they put coal, literally pulled from the ground outside their house to heat them. And they often didn't have enough food to feed their families. And this is well before I understood what a housing shortage was, and well before I understood what food insecurity was, and well before I understood what the impact of not having enough income um, was to be able to and how it would affect a family's health. And I spent just over 3 years in that rural community in Kentucky, and I realized that I thought I was there to take care of children, and I realized I couldn't take care of children unless I knew how to take care of moms. Because if that mom didn't believe what I was doing in pediatrics, I certainly wasn't going to be able to take care of their child. And that if that mom who came down from that hill or that holler to see me, often coming with a grandma, that if I didn't know how to convince that grandmother and that mother that I knew what I was doing and respect what they thought needed to be done, because there's a lot of rural culture in those hills and hollers. And you'll notice I'm really avoiding saying anything about a term hillbilly, because that's not a term of respect. These are mountain folk, and I needed to respect their treatments and their culture and their history of taking care of families. And I suddenly realized I wasn't really in the pediatric business. I was in the family business, and I wasn't really in the family business. I was in the hill and holler business, because they would visit everyone coming down from the hill on the way to the hospital, and I needed to embrace what they were embracing if I was going to make any difference with this child. And as time went by, I realized I really wasn't truthfully in the clinician business. I was in the future of children business, because these children needed to dream as to how they might be able to survive in a community that had little or no future. And that small community that I moved to so many years ago had um, had only 500 people in its largest town, and now it has only 300 people in its largest town. And I, I decided that I needed to reframe my world and say I needed to be in the future of children. I returned to North Carolina. I got a master's of public health, and I thought, well, this is a way to start thinking about how to take care of a broader community. And as Ross pointed out, I came to Wake County Human Service Agency and became the medical director, and began to realize that we need to see the people we're taking care of. We need to hear the people we're taking care of. We need to be in relationship with the people that we're taking care of. And I spent 27 years with Wake County Human Services trying to figure out how just to do that, whether it be through our programs to reduce infant mortality, or whether it be through our program to try to address the HIV/AIDS epidemic as it first came to our community, or when measles reemerged as an endemic problem. How were we going to touch the people who were most affected by it, respect their issues and their fears, and calm their concerns about vaccines? Does this sound familiar to you? About vaccines, so that we could try to better protect people against something that was widespread, hurting children, hurting families, keeping kids from going to school, and do it by creating relationship with the people who we were going to serve. Now, sometimes when I do this talk about historically marginalized populations, or about considerations, I show a slide, and we're not going to show that slide, but I want you to imagine with me that I just popped a slide up here, and it's the common causes of death and suffering. And it can be a really complicated slide, as you might imagine, but it hasn't changed much since the time I became a physician. It still shows that the leading cause of death in the United States is heart disease, and that unfortunately, unintentional injury has popped up into second place. It didn't used to be there. Chronic respiratory diseases are still number three in that area, and cancers are number 4. But without even worrying about the numbers, does it surprise you that conditions that we know how to treat, we know how to treat heart disease, we know how to treat cancers, we know how to treat diabetes, we know how to treat pneumonia and influenza, we know how to treat the kidney diseases, we know how to treat so many of these conditions, and they're still the top 10 killers in the United States. And worse, when we start talking about historically marginalized individuals, whether they be the people who live in Appalachia, whether they be the people who live in our state, the Black and brown people of our state, we know how to do this, and yet they remain the top 10 causes of death in our state. And worse, we know that we're unable to treat some of the folks who have these conditions because they don't have access to the healthcare. They can't simply get to where the healthcare is, or even worse, we fail to create the relationships between ourselves and individuals so that they actually trust what it is we're doing. You know, they say that doctors really need to ask just 3 questions when they see a patient. They need to ask, how's that medicine working for you? Are you taking it? And if there's any hesitation to that question, are you getting to take all of your medicine? Pretty much you can guess that they're not taking all of their medication. And I'm not saying they're not taking their medication because they don't want to. I'm saying they're not taking the medication because they can't afford to. And then if you say, well, is there anything about that medication that kind of worries you? People will open up and tell you, well, yeah, doc, I'm worried about a side effect of that medication. Could it be doing this? Could it be doing that? And if you add a third question, which is, do you think there's anything in that medicine that might be hurting you? And if you've developed that relationship and you've developed that trust, they'll say, well, Well, yeah, actually, I heard something about it hurting you. And gosh, if any of you watch any TV and see those drug ads on the TV, you don't have to try very hard to find out what you think some of the medicines could be hurting you, because they list all the things about those medications that could be hurting you. So we have all these medicines, all these things that could actually treat heart disease, treat kidney disease, treat diabetes. And you either can't get to a doctor who will treat you, can't afford the doctor who will treat you, can't afford the medicines that will treat you, or wonder whether those medicines actually will harm you. And then we say, why is there a difference? Why is there a difference in the outcomes between our historically marginalized populations and our Caucasian, our white populations? And it's because we haven't had this opportunity to build a relationship with folks and to have an opportunity to actually talk with folks and say, ask me your questions, ask me what you have there, and I'll do my best to tell you which of your questions are the really, really good questions that I have to say, you got a good question there. And it's a hard one for me to answer, but I can tell you the medicine that you might be worrying about, that's not the one I'd worry about. That's the one I'd say, let's go ahead and say, let's try one that might have a different side effect profile. Let's try one that we should do something different with. But beyond the medicine, if I can, beyond the medicine, if I please can, there's another curve, another slide I show people. And it's this big slide that shows the countries of the world, and it shows how much each country of the world spends on health care versus how much they spend on health. And that's, I think, one of the big points that Dr. Rasheeda Monroe and I want to speak to you about today, and that is that this country spends more money on healthcare than any nation in the world. But we don't spend more money on health than any nation in the world. And what do we mean by that? To spend money on health means to spend money on a living wage, to spend money on affordable housing, to spend money so that people don't go hungry, to spend money so that people can afford to have childcare, to spend money so that families can put food on the table so their families can eat, and not just eat, but that they can eat healthy foods. And when I left Wake County, it was now almost 9 years ago, retiring supposedly from Wake County. I was retired for 3 days. I retired from Wake County and became the executive director of Urban Ministries 3 days later, because Urban Ministries not only had a clinic, but it had a food pantry, and not only had a food pantry, but it had a shelter for the homeless, and not only had a shelter for the homeless, but it had programs to help people whose lives were in crisis, so that we could try to say, how do we address these social drivers of health? How do we argue for a living wage? How do we argue for affordable housing? How do we argue and advocate so that no one goes hungry? And this is, I think, what we need to be talking about more and more, is that while it's my job as a physician to try to make certain that people have access to affordable health care, quality health care that is accessible and acceptable to you, meaning that it's something that you can feel free to ask any and every question, and that you feel that you can disagree with me about certain things. It's also my job to make certain that you see health as the goal we're striving for, not simply health care as the goal that we're striving for, and that health is something that you're engaged in, and that health is something that we can be engaged in together, and try to make certain that in this respectful relationship, you're not a patient. Patient is such a word that is implies that you sit there with no active role. You're a partner in health, and as a partner in health, mean, I see you 4 days a year, perhaps. The other 361 days a year, what can I do to empower you to be someone who says, these are the things I can do to improve the care of my diabetes. These are the things I can do to improve the care of my hypertension, because those two conditions are so correlated with these top killers and these top um, conditions that literally change the quality of your life. And what can we do together to improve the quality of your life? And and how can we do that with compassion? How can we do that with care? How can we do that to maintain dignity? Because that's what this ought to be about, welcoming you to come in to our world, and in this time of COVID, frankly, to not come into our world. How can we do this? By inviting you to join us on the phone, to join us on a computer if you have broadband, but to join us on the phone at a time of your convenience, not making you have to drive to where we are, allowing you to have that time on your break from work, on your lunch break, on your morning break, to be able to make that connection and meet and greet and try to make your access to quality care something that is at your convenience, not at my convenience, and have it be something that you share, we create the goal together to make certain you can have the type of health you like by having the type of health care you might like, which includes improving your health in many facets of your life. And I think that's what we're trying to talk about today. And I know that Dr. Monroe will have a lot to say about that. And I'd like to see if Dr. Monroe wants to take the screen now and share her stories.
For those who don't know Dr. Peter Morris, now you can understand why I'm such a fangirl today. See, I wrote a whole page just of quotes from him of ways that we reframe what we're saying. I love that being in community with those we serve and being not a patient but a partner in health. That's so powerful. That is just so that just free that is freeing, and that is such that your words are so powerful. You speak so softly but so loudly. And I could keep gushing, but I know that's not what I'm supposed to be doing.
Oh,
Ross,
keep it going, Ben. Go ahead. Give it to him. He deserves it.
I mean, wow. We'll doing the Q&A at the end. We'll delve a little further. I still got to sit with some of this for a moment, but thank you, and God bless. Um, Ross, you want to introduce our next superstar?
Yeah, it would be my pleasure, and I apologize for the technical issues, but this is the show that Betty and I were looking forward to since we started this series, really. And to have Dr. Peter Morris and Dr. Rasheeda Monroe as our two guests is just, to be honest, it's just beyond anything that I thought that we could even wish for. So we're just so delighted to welcome them both here. And so you've met Peter, and everything Betty said is true. And I've known Peter personally. I've worked with him when he was with Wake County. And he has just dedicated his life to this work and is so passionate about it. And he's made such a difference to so many. And I understand that he actually, our next doc, Dr. Rasheeda Monroe, did her residency with Dr. Morris. Not to date you, Peter. I don't think that you and I are that different in age, but so Dr. Rasheeda Monroe has been featured on not just the local news, but also on national news for some of the work that she did. And I don't want to steal your presentation because I understand you're just an exceptional narrator. But I know that WakeMed came to her with a challenge. Dr. Monroe said, I really need to be part of the solution and reach out to the historically marginalized population to make sure that they have the access to the vaccine that other folks do. And WakeMed, I understand, said, well, if you can come up with 300 people, then we'll talk. And my understanding is within a day, she had 700.
So that's the kind of person Dr. Monroe is. And just working with her in the last 48 hours through our technical issues, I can tell you she is somebody that does not give up. So with that, I'd like to turn it over to Dr. Rasheeda Monroe.
Awesome. Thank you so much, everyone. Thanks, Ross. That was a really beautiful introduction. And I feel like this is like an urban legend that the story gets bigger and bigger as we tell it. But that's pretty close to what happened. I am excited to be here today, and it is indeed true that I trained. I did part of my training under Dr. Morrison. He has been someone I've looked up to for a long time. So I'm really happy to be a part of this. So I want to tell a story about what collective action between engaged community, faith partners, and passionate physicians and other staff, what we can do, what we did do to help close some health disparities. So I want to tell that story, but I'm also going to tell you the story about the community in which we work and how this community was shaped. So let's start with fall of 2020. In fall of 2020, the COVID pandemic was raging. What we saw was that Black and Brown communities were disproportionately impacted by COVID. So 3 times the rates of hospitalizations or deaths were seen in Black and Brown communities. And the 27610 zip code, so Southeast Raleigh, was not spared in this. There was an article from fall of 2020 in the on WRAL that there had been disproportionately higher cases in that specific zip code 27610 than throughout the entire state. But what we also saw at that time in early 2021, when the vaccine rollout started, the COVID-19 vaccines rollout started, that the people who were having access to that life-saving vaccine were not the people who had been most impacted by the pandemic. And so we were seeing that, richer and whiter neighborhoods had vaccine sites that were near them, had, the internet and infrastructure and transportation and access to register and get these vaccines, and that our community members in Black and Brown neighborhoods were not getting that same access. And so we saw this, and I say we because this is nowhere near a solo effort. I worked with a group of women. We call ourselves the Sister Circle. We're a group of African-American women physicians at WakeMed in different areas. I'm in pediatrics. We have OBGYN, family medicine, obesity medicine, psychiatry represented. And we had started with an education campaign and a social media campaign of us getting vaccinated, encouraging our community members to get vaccinated. But when we saw in early 2021 that we weren't having the same access, our community wasn't having the same access, we wanted to do something about that. So we worked with WakeMed, Wake County, Lachelle Wardell, we call her honorary Sister Circle because of the amazing contributions to this vaccination campaign. And most importantly, our faith community in Southeast Raleigh. And what we decided to do was take the trusted messengers. We used the Sister Circle and other people in our health equity team, often women and physicians and nurses and nurse practitioners, people of color, to be the trusted messengers to go into Southeast Raleigh, but really in partnership with the pastor community. We worked with mosques, we worked with the Guatemalan and Mexican consulates, and we said, you guys are experts in your community and people trust you. How can we partner together to directly bring vaccine to sites in your community, where we can break down the barriers of transportation, lack of internet access or computer skills, or even trust. How can we break that down and bring these vaccines? And so that's what we did. And as Ross was mentioning, initially, I think everyone in this effort, when we think about historically marginalized populations, we think of a legacy of mistrust as it pertains to medicine. And many people thought, well, Black and Brown people aren't getting vaccinated because they don't trust the vaccine, because they don't trust medicine, because, the Tuskegee syphilis experiment and all these different atrocities that have happened in not a foreign country, right here in the United States over the course of hundreds of years, and some that are ongoing. That's why people aren't getting vaccinated. But that's not what we found. We found that people were absolutely eager and desperate to get vaccinated. And once we made it accessible to them, we were vaccinating people in droves. We ended up vaccinating between 1,000 and 2,000 people per weekend over the course of several months in early 2021. We administered over 14,000 doses in arms. So that's 7,000 people specifically from historically marginalized communities who were protected from COVID, not going to spread COVID to their family, or contract it themselves. And so that work is, ongoing in different ways. Again, we're not vaccinating 1,000 to 2,000 people anymore. This is what we call hand-to-hand combat, where it's individual conversations, individual people, one at a time, reaching those who still, are hesitant and reluctant, having those personal conversations. So I wanted to tell you that story of how a faith, community, and health system collaboration was successful in closing a disparity gap. If you look at the North Carolina DHHS vaccine tracker over that time, you can see that with every large-scale event, the percent of the population, African-American population that was vaccinated, increased by almost a percentage point at a time, and that's for the entire state. So this small area, this volunteer army of health equity crusaders helped to move the needle that much. But I think it's really important that we understand the factors that shape the community in which we are working. If you look at a redlining map, okay, from the mid-1900s, and you look to see the intentionality which the federal government used to, through HOLC, Homeowners Loan Corporation, to decide in which communities would they invest, where would they approve, mortgages for people to be able to buy homes. And if you look at a redlining map from the mid-1900s and you overlay that with a map in any major city in the United States, you can see that there are areas of concentrated poverty and concentrated Black and Brown communities, and those same areas in which the federal government systematically and specifically and with intention did not invest in. You overlay that with a COVID hotspot map in which there's been more cases, deaths, and impact from COVID, and those things all coincide. And so when you think about the FHA loans that help build wealth in America, but specifically in white America, because 98% of those loans went to white families and created generational wealth. That's, been the reason why, their descendants have been able to go to college and put down payments on homes and land and things like that. That is all very directly related. There's a wonderful book called The Color of Law by Richard Rothstein. and it tells a specific story about Southeast Raleigh. So it tells the story of the neighborhoods, College Park and Idlewild. These were neighborhoods in North Raleigh that were Black neighborhoods with families who owned homes in the 1920s. So I want you to first think about it and think, what did it take to be a Black homeowner in the 1920s? And so these were families who were, who were doing well financially and had been able to build, start to build a legacy for their descendants that started with home ownership. Well, Raleigh used school segregation as an intentional tool to break up these neighborhoods. So in addition to home ownership, home mortgages, another intentional tool that our federal, local, and state government used to further disenfranchise Black and Brown communities was school segregation. So the only school then that the children of these Black families could attend was then placed in Southeast Raleigh, and the quote is, between the town dump and a rock quarry. So right here in Southeast Raleigh in the 27610 zip code. And those neighborhoods then were essentially relocated, and you can go right down the street on Rock Quarry Road, right down the street from where I am right now practicing, and see those neighborhoods, College Park and Idlewild. And that land then in North Raleigh, where these families had been and had to relocate so that their children could attend the only school that was available to them, that land then prospered greatly over the next century. And there was business investment and economic investment and residential build. And if you go to North Raleigh today, you see it's a very different economic and investment environment as compared to Southeast Raleigh, where we are right now. Another tool that was used by federal and local governments was where the federal highway system and roads were placed. There is a wonderful documentary that tells the story of the village of Oberlin, which is located right down the street again from where I practiced here in Southeast Raleigh. And the village of Oberlin was a freedmen's village that was started after emancipation after 1865. And what was so phenomenal about the village of Oberlin is that it was an all-Black village, and it was considered the premier suburb of Raleigh, not the premier Black suburb, the premier suburb of Raleigh. And it produced a disproportionate amount of doctors, lawyers, and teachers than any other area in the city. And it was an all-Black village. It was truly a remarkable place. The story, or the documentary, The Village of Oberlin, gives firsthand accounts of children who grew up there, and what a beautiful, wonderful, and prosperous time that was for them and their families. Despite setbacks like the Great Depression and the Great Migration North in the 1920s, despite these things, that village continued to grow and prosper and produce, these wonderfully, talented, children and adults who, contributed to their communities. But it was in the 1950s and 60s when land development, specifically the building of Wade Avenue and widening of different streets, really cut off and essentially destroyed the village of Oberlin. It was the development of Cameron Village, named after the most prominent slave owner in North Carolina at the time that the village of Oberlin was created after emancipation. It was the creation of that residential and commercial space and the access roads to it that essentially destroyed the village of Oberlin. So again, another tool that was used. And we think of, again, land and home ownership being the largest tool of wealth building, and it's passed down generationally. One further local example in Southeast Raleigh, we think about the Leonard Medical School. The Leonard Medical School was the first 4-year medical school in the entire country. So not in Raleigh, not in the state of North Carolina, but the entire country. And it was located right here in Southeast Raleigh, and it trained and produced Black physicians that contributed to their community, passed their medical board exams, and by all accounts, all historical accounts, were very competent physicians. And it was associated with Shaw University. St. Agnes Hospital was also located right in the same zip code in Southeast Raleigh, associated with St. Augustine's College. And while Leonard Medical School produced physicians of color, St. Agnes Hospital trained many nurses of color, and both were really essential and important parts of not just the Southeast Raleigh community, but really the Black community in the South. So St. Agnes Hospital was described as the only place that a Black person could get adequate care between DC and Atlanta. So think about that right here in our own backyard. Well, the Leonard Medical School was up and running and productive for several decades, until the Flexner report was published, and there were consequences of that. Now, the Flexner report, for physicians and public health students, you may remember the way I learned the Flexner report as a medical student was it was this amazing report by I think it's Abraham Flexner, sponsored by the Rockefeller family, that standardized medical care in America. So prior to that, to be a doctor, you could take courses that weren't in person, that you could, basically pay to get your degree. There wasn't standard of training or research or clinical exposure. When someone was able to hang a shingle that said they were a doctor, it was really variable in what their training and expertise and competence was. And so the Flexner report evaluated all the medical school, or many of the medical schools in the country, and decided what things that they would laud and highlight, and what things should be standard, for medical school curriculum to make sure we're producing competent physicians. Well, that's how I learned it in medical school. And that sounds great, right? Standardizing care. But what I did not learn in medical school, what I did not understand until more recently, is that the Flexner report was responsible for the closing of the vast majority of medical schools that trained physicians of color and women. One of which was the Leonard Medical School. Now, remember, the goal of the Flexner report was to standardize medicine, to have a clinical curriculum, to emphasize research, and to produce competent, well-trained physicians who could contribute to their communities and pass their board examinations, which the Leonard Medical School was doing. But what they really also emphasized through this Flexner report was a training model that was more associated with very well-funded, more likely to be white schools, white medical schools. And so if they were associated with a hospital or a research facility, or had a certain amount of funds, and investment. And so the only two then historically Black medical schools that survived were Meharry and Howard. And we still see the impacts of that today. For then more than a generation, not more than about 2% of the doctors being trained in this country were physicians of color, and we're barely more than that today. About 5% of the practicing physicians are Black. When we comprise about 13% of the population. And so we also know that historically marginalized populations who are more likely to live in areas with disinvestment, as we discussed with the FHA and redlining, are more likely to have concentrated poverty, low access to high quality groceries, green spaces, more likely to be near toxic waste and increased rates of cancer and asthma. And when we put all these things together and we see these communities with higher rates of diabetes and hypertension, we really have to understand the historical factors that shaped these communities, and realize that research shows that physicians of color are more likely to have positive outcomes with communities of color, whether it's because they identify and are trusted by, are able to bridge, cultural or, educational divides, are kind of more speak to those communities. So if we don't produce physicians of color, we're unable to adequately address this in communities of color. So I just give you those couple, there are more, of local examples, Southeast Raleigh 27610 examples that shaped these communities. So the Leonard Medical School was closed, and then St. Agnes Hospital was closed in the early 1960s when my hospital, Wake Med, under a different name, but when Wake Med opened. And it was the first, well, it wasn't the first because St. Agnes was actually an integrated hospital, but it was the community hospital that was then integrated, though the Black physicians took care of Black patients on a different floor than white physicians took care of white patients, but it was considered an integrated hospital. And the opening of that hospital essentially closed down St. Agnes Hospital. St. Agnes was a really important economic engine in Southeast Raleigh. When you think about the gas station across the street and the funeral home and the florist and all of these different businesses that are impacted by the economics of St. Agnes Hospital, and you understand why the closing of that hospital, not just because there wasn't that local and accessible community partnership from a health standpoint, but also the economic impact of that hospital no longer being open and present serving the Southeast Raleigh community. So I tell those few stories to help lay the landscape of when you add economic disinvestment, historical marginalization that was sponsored by our federal government. It was not unintentional. And you overlay that with a worldwide pandemic where being able to socially distance is important. Being able to, stay at home and is important, and have access to adequate health care. And then we look at our, Southeast Raleigh community that's more likely to have, multi-generational, multiple generations living in a home and spaces that you're not adequately able to, isolate and quarantine. All of those factors come together in the most imperfect storm to create the conditions that led us to do the work that we did in 2021 from a vaccination standpoint. So I'll stop there because I know I'm over time, but thank you for giving me the opportunity to just tell that story of the work we did and the community in which we were able to do that work.
All right. Well, just for the record, you have as much time as you need. I mean, I'm just so impressed. I mean, the thing I noticed is she doesn't have a single note in front of her. And so she just said all this, and what a rich context to everything. I learned so much just in the last 15 minutes listening to you, Dr. Monroe. And you really did a great job of sort of showing us how we got to where we are, not just with healthcare, but as a society. What are the conditions? What are the decisions that led to where we are today? So thank you for that, Betty.
Don't get me started. Oh my gosh, Dr. Monroe, I'm fangirling again. I'm telling you, and as one of those people that you said were eager and desperate to get the vaccination, on behalf of me, my sister, my whole tribe, my community, the 500 to 600 people that my sister and I helped to register, thank you, thank you. You saved lives, and I know as a doctor that you probably hear that all the time, but I am certain that you saved lives. And that is just something that the community, I think we need a monument down at the Confederate Square. These are the people we need to be making monuments to. But yeah, we were trying very hard to get in January to get vaccinated, trying really hard, signing up. I was signed up in 4 counties. My sister and I, we have computers, we have cars, we have all the things we needed but we didn't have access. And so your experiment, we were 2 of the people who got in to get those first group of vaccinations. And then when I posted it on social media to encourage other people to do it, that's when they started contacting us going, how did you get in? We can't get in, help us out. And so we started what we call the Underground Railroad. And we started texting people, calling people, working through some of the groups were the Divine Nine and other groups, but we started a network. And Lachelle Waddell, who I also idolize her, she would call and say, well, Betty, we're going to be at this church. And I said, save me 10 slots there. And then I would get Vielka Gabrielle would say, we're having a vaccine clinic at this church, at my church in Southeast Raleigh. I said, save me 10 slots there. And then all of the people that were calling, I mean, I had a notebook with names and numbers, birthdays. People were like, you need my social security number. What can I get? What do you need? Just tell me. I want to get a vaccination. These were all people in the 55 and over age group. And, you know, we were all very eager and desperate. You said it right. So I just want you to know that the impact of your work spread far and near, and it really it did a lot to help us all, saved our lives. So I thank you for that, and I hope that I think we have some questions. Yeah, you just yeah. It's not something I can talk about you know, subjectively, because it's personal. It's very personal for me, and I know all of the information that you gave. I'm a member of Raleigh Organizing Against Racism, and we bring in the Racial Equity Institute to do workshops for us here in Wake County, and we talk about the historical racism, the historical barriers that created these communities, the redlining, the discrimination in housing and everything. And it is so important. What you and Peter both said resonates so deeply with me. And I think it's important that we have these conversations and address these issues, especially in healthcare. Especially in healthcare. So I'm going to check with Em and Rachel to see if there are audience questions, because if not, I have some.
I thank you all for this conversation. So necessary and appreciated. So not a question, but a comment.
Linda. Yeah, thanks, Linda.
Which is not at all surprising. I mean, you all both did such a fantastic job, and you're both so skilled at having these conversations, which are not easy conversations. So thank you for that. We do have a slide, and if I could pull that up. This is one of the latest slides from Wake County when we're talking about vaccinations. I know this is super hard to read, but Wake County, with historically marginalized population, and particularly populations of color, is doing much better than when compared to the rest of North Carolina. And that, all I could think about was this slide when I was listening to you, Dr. Monroe, and knowing that Betty did a yeoman's job of out there getting people registered for some of the available slots. I wonder what this slide might look like if it weren't for you, Dr. Morris, and Betty. I can't help but think it would not be as good as it is now. There's still work to do, but you guys had a positive impact to be sure. So thank you.
One of the questions I would like to ask is, I know that in some states where there is not enough beds or not enough supplies and not enough equipment, that they're having to, and I know there's a term for it, and I was trying to find it, but they are having to make decisions on who gets on ventilators and who doesn't. And I know that as a woman of color, my age, and health challenges, if it was a choice between me and an 18-year-old white girl, I know who would get the ventilator. So can one of you speak about that? I don't remember, whether it's Idaho or somewhere.
Yeah, I want to talk about that, Betty, because it's so, so important for people to understand. And I have said this since the beginning. We do not want to get to the place where we are rationing care. And we are not quite there here yet, but that can happen to anybody. That can happen in any state. With these surges, we had to expand our hospital capacity. We were over capacity. We were turning conference rooms into patient rooms and turning lobbies into overflow emergency departments. And this is what's important to understand. When we're at the point where we're rationing care, part of the calculus, part of the equation is survivability, right? Who is most likely to survive? And when you think about, as we've described over the past hour, the communities who are more likely to have higher rates of those high-risk conditions that make survival from COVID less likely, okay, Black and brown communities with increased rates of heart disease, diabetes, and hypertension, there is a built-in disadvantage to that calculus, okay? And so the most important thing we can do is get vaccinated and do all the things, social distance and wear a mask, and get vaccinated and get vaccinated and get vaccinated and convince someone else to get vaccinated. Because the best thing about the vaccines is that they make it dramatically less likely that you will ever be in that situation where someone is deciding, do you get the last ventilator?
Yeah.
Right?
Yes.
And the other thing I want to put in a plug for is monoclonal antibodies, because monoclonal antibody infusions, if you test positive for COVID, and the first 10 days of testing positive before you need to be hospitalized, so still, walking around in the, at your house, not in the community, at your house in isolation. If you get monoclonal antibodies, which are free and available in your community, it decreases the likelihood that you will be hospitalized by 70%. It really, really, really is a game changer. And we've had access to monoclonal antibodies for a very long time, and people just didn't understand that they should be seeking them out. And so the way you would do that, if you have a primary care physician, would be through your family physician or your primary care physician. If you don't have a primary care physician, you still have access to monoclonal antibodies. So you're like in Wake County, Wake Med has the monoclonal antibody infusion center. And so you really can reach out to your health system you don't need insurance. So I think those are two huge things to remember. Get vaccinated. Don't let the decision whether you get the last ventilator or not be someone else's, and prevent hospitalization whether you're vaccinated or not. If you get COVID, look for monoclonal antibodies. And conditions under which you could get monoclonal antibodies, it's gotten easier. I mean, if you're an adult with a BMI, a body mass index over 25, and that's just a little bit overweight. I mean, I don't think I'm that overweight. My BMI is over 25. I don't have diabetes, heart disease, or high blood pressure, but I would qualify for monoclonal antibodies. So keep that in mind.
And just to reinforce what Dr. Monroe said, when they were first talking about the monoclonal antibodies, there was, I believe, just as she said before, there was a biased statement in there. They said, oh, consult your physician to see if you're a candidate for monoclonal antibodies. And I thought, there are 110,000 people in our community who don't have a physician, and most of them are people of color. But there is a standing order signed by Dr. Betsy Tilson, who's our state health director, that authorizes people to give the monoclonal antibodies. So I'm completely with Dr. Monroe. Don't fear getting tested. If you believe you may have symptoms of COVID, and the symptoms of the Delta variant are a little bit more subtle than the symptoms of the Alpha variant. It tends to be congestion, pretty severe congestion, but it tends to be congestion, a little bit of a lower fever, and it tends to be fatigue. Don't mess around. Get yourself tested. The testing is free. The testing is available at a lot of pharmacies, but the Wake County sites are open from 7 in the morning till 7 in the evening, 6 days a week. And the results come back very quickly. And if you have the classic conditions that people worry about, which is the hypertension and the diabetes and the respiratory disease, you should not be messing around. But as Dr. Monroe said, BMI of 25 and above, I have a BMI over 25, and I don't think of myself as being particularly overweight, but you should be consulting, and you should be going to one of those centers and saying, am I a candidate for these monoclonal antibodies? And do it sooner rather than later so that you might be able to prevent progressing to the point of needing a hospitalization and taking care of yourself. I don't think it's well enough known by the public that these are not being reserved just for the wealthy, not being reserved just for the politically connected, not being reserved for people who have privilege. These are out there for people who are regular folks. The other thing, I don't know what Dr. Monroe might like to say, but although I make a big difference between people who are vaccine resistant, who, by the way, are getting vaccinated more and more in smaller numbers, and vaccine hesitant. For people who are vaccine hesitant, it's very interesting that the people who often convince them to become vaccinated are not necessarily health folks. They're not health professionals. They are friends. They are neighbors. They are folks who speak out and say, I decided to get vaccinated. And you don't have to give a fancy reason. You just give your reason. That I decided to get vaccinated for my grandchild. I decided to get vaccinated for my sister. I decided to get vaccinated. Very personal reasons, because you're in relationship with people, can be very great reasons for someone else to get vaccinated. So it doesn't have to be fancy. Now, if people ask me, I'll often say, oh, well, what's your hesitation? And they'll mention 2 or 3 reasons. And what I try to do is not disrespect someone, but I'll say, oh, well, 2 of the reasons you gave me really are vaccine myths. So if you don't mind my saying so, push those aside. Mm-hmm. Now, the one reason you have left, that one, think about it. Mm-hmm. But I don't think you have to think too hard, personally. Mm-hmm. Don't let the myths get in the way of your making a good decision. Because I'm not mocking people when I do that. I'm just saying, push those ones aside. They're really not very good. You do have one good one. It's not that good. I'm not. It's just respecting people.
Yeah.
And, when you line them up like 4 or 5 reasons, it's like, where do I start? Well, you start by taking the 4 bad ones, come up there, and come back with the one good one. Address that one. Talk to a friend. They'll tell you that they overcame that one. go for it.
I think we actually have a question for the two of you now from Rachel, if you want to put that back up. And I know that our speakers have to get on their way. They have other things. They're obviously very busy people. But the question from Rachel is, what is the largest healthcare challenge facing our minority communities?
I want to answer this one. Again, Peter, I'm just going to jump in. Because if you'd asked me this 10, 15 years ago, 15 years ago, 20 years ago during my training, I would have said a completely different thing. Today, I am convinced that the biggest threat is structural racism. Mm-hmm. And let me explain to you why I say that. Because really, it is the upstream cause of all these downstream effects. Right? Yes, we, Black and brown communities have increased rates of, you name it. We've named them. But when we look at the structures, whether it's in healthcare, education, housing, banking, policing, that impact communities, and what those structures, how those structures have impacted communities, I really believe that dismantling from the root is the only way to really address what's a downstream effect of, all of these other kind of healthcare conditions. Peter, what do you think?
I think you're dead on right. And I think of my civil rights heroes and wonder what they would say is, how do you face that structural racism? And we've got a lot of work to do, obviously, but I think we have, more and more people like Dr. Monroe and people in her system, the Wake Med system, which is the system I've worked with, and the Wake County Human Services I've worked with, I would say dive into it and ask for, demand if need be, the care that you need. And don't be afraid to do so, because I think people are trying to step up to address some of those causes, and you deserve better, and you should ask for better.
Amen.
Yeah, well put, Peter.
Yes.
One more question, and I know you all have to go, but if you would just indulge us for one more question from somebody that's one of our viewers on YouTube. Could you speak to some of the breakthrough cases? Could you speak about some of those breakthrough cases?
I certainly can. Peter, do you want to go first?
No, I talk all the time.
Okay.
Listen to your answer.
So there certainly are breakthrough cases. I don't even know if we want to call them breakthrough cases. There are people who have gotten fully vaccinated. They're 2 weeks post their second vaccine, and they got COVID. Well, that's really to be expected, because the efficacy of the COVID vaccines with Alpha variant was, 94, 95%, and looks like it's a little less so with the Delta variant. But what we're looking at is, well, so first of all, I'm a pediatrician, and what I do every day, all day, is vaccines. And 95% efficacy is kind of unheard of in vaccinations generally. I mean, the flu vaccine that I encourage everyone to get annually is usually much less effective than that. The vaccines that you had to get for your children to enter kindergarten, they're, varicella and MMR and, these different vaccines, the reason that they're so effective is that our whole community gets vaccinated, and we get herd immunity that helps to prevent measles from re-entering a community. So let's start with that. We know and expect that vaccines will not be 100%, but the most important thing, even with these breakthrough cases, is that it's preventing people from getting very ill, hospitalized, on a ventilator, and dying. So the vaccines are still doing their job, even with Delta variant. The people who have had breakthrough cases have usually had more mild symptoms that resolve more quickly. And so, feeling better within, a couple of days versus still suffering for a couple of weeks, or even, kind of long haul symptoms that, that we've been seeing over the past year. So, to be expected, and still doing their job.
And I agree completely. And to say it in a shorter sentence, the vaccines are doing exactly what they were designed and tested to do. They were designed and tested to prevent hospitalization, prevent ICU admission, and prevent death. This term breakthrough is actually an incorrect term, because people who have been vaccinated are very, 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 notice all the varies, rarely hospitalized. They do not wind up in ICUs, and they do not wind up dying. The vaccine does exactly what it was designed to do.
Oh, Betty, you're on mute. Really good answers, as expected from both of you. Okay, I'm going to go ahead and say on the record, favorite show ever for me, Betty.
Yeah, me too. Definitely.
Best guest ever
Definitely.
too, right?
Yeah, I'm going to be sending the link out to people who weren't able to get on. I think a lot of folks, some of my friends and other colleagues were on today, but you guys have been amazing. My word for you all comes from a saying that Dean Cain, who played Superman in an old movie, he said, real heroes don't wear capes. Real superheroes wear uniforms. I inserted scrubs and stethoscopes. And I would also add cowboy boots because I know that Peter Morris is a big fan of cowboy boots. So instead of those capes, our superheroes are wearing scrubs. So I can't thank you both enough for your time today and for framing for us and for the community where these issues began, and that will help us inform us as we're looking to resolve some of these issues. So if M will put up the slide, I wanted to review this because it's certainly pertinent to today. The 4 pillars that we address in Northern Lights. Our theme for this year is health and healing. And the issues that we agreed we were going to address this year are race relations, because we know that racism plays a big part in our communities not being healthy. We want to look at health disparities, which was our topic for today, that was masterfully done by Drs. Monroe and Morris. We're looking at expanding partnerships, bringing in other nonprofit groups who are doing work that our community needs, and helping us to make referrals, and also education and outreach. And that's the purpose of Northern Lights, is education and outreach. And with that, I'll see if you have some final thoughts, Ross, before we sign off.
I don't. Other than, if you were here for the full 1 hour and 12 minutes, that was time well spent, and to be sure. And the great thing about this is that this will live forever on our Facebook page. And so please do share this information with your circle. And we look forward to you joining us next month when we're going to continue this conversation. We kind of did a little bit of a twofer today when we talked about those 4 corners, when we got a little bit about race relations, and we have a little bit about health disparities. But we want to continue to be in that upper half of the sheet. So we're going to continue this conversation next month, and I hope you will join us then. And Betty, as always, thank you so much. It's as I say, Betty is really the star of the show. And so she stepped up today when I was having technical difficulties and did my part. I'm sure she did it seamlessly. So thank you for that, Betty. As always, really appreciate it. And
you're very welcome. You're very welcome, Ross. And I can't tell you how great it is to work with Ross. Those of us who have the opportunity to be near him and be with him. And I want to bring M and Rachel out as we bring up our very last slide. To show the producers behind this program. We did have technical difficulties, but M and Rachel always come through, and they're always great with making things work out. So our very last slide, as we get ready to shut down, wish Ross a very, very happy birthday. Today is his birthday.
Happy birthday.
Thank you. Well, this is going to be part of the permanent feed now. Well, thank you so much. It's I couldn't think of a better way to spend my day than with you guys. So it's awesome. So thank you very much for that.
We thank you, Ross. You did. You shared your special day with us, and we're very appreciative. And we
That was
can
my
never
pleasure.
thank Dr. Morris and Dr. Monroe enough for their hard work. And hopefully they'll come back again.
Yes. All right. Bye, y'all.
Bye. Thank you. Thank you all.